Everyone, and welcome all. Thank you for tuning in to this evening. My name is Hash Abdeen, and I'm the current chair of the AMA Federal Council of Doctors in Training and your host for this evening. But before we begin, I would like to start by acknowledging the Bindul and Wulungurru Kaba people on which lands I'm hosting this meeting tonight. I acknowledge the traditional custodians of the various lands on which you are all meeting and pay my respects to their elders past and present. I would also like to extend that respect to any Aboriginal and Torres Strait Islander people participating in the webinar this evening. So tonight we have a very interesting panel for you composed of some amazing doctors in training, and I encourage anyone who has a question to please comment in the chat function. We, the AMA CDT, want to hear what issues are important for you so that we can continue to address these and advocate on your behalf and with you. Now, without further ado, let's meet our distinguished panel who will be answering questions about training, about issues that concern you and us as doctors in training. So I'll start with our first panelist, Dr. Bav Manoharan, who's the Vice President of AMA Queensland. Bav, did you want to quickly introduce yourself?
Thanks, Hash. Hi, everyone. So as Hash said, my name's Bav. I am technically still a doctor in training. I'm a medical administration registrar based currently working at Logan Hospital in Brisbane. I've got a few hats on in the hospital. I'm acting Deputy Director of Medical Services as well as the Director of Obstetrics and Gynecology. So lots of things to do as a doctor in training.
Thanks, Bav. Next up, we have Maddie Taylor, who is the chair of the AMA Queensland Council of Doctors in Training. Maddie?
Thanks, Ash. Yeah, I'm Maddie, everyone, and I'm one of the BPTs up at Townsville Hospital at the moment in my first year of registrar training.
Thanks, Maddie. Next, we have Helena Franco, who I believe, it says resident medical officer, but you're a PHO, Helena, now? That's right.
Yeah, I'm one of the orthopaedic PHOs at the Royal Brisbane and Women's Hospital, and I'm Deputy Chair of the AMA Queensland Council of Doctors in Training, working with Maddie.
Thank you. And last but not least, we have Tessa Kennedy, who's a paediatric intensive care trainee at the Sydney Children's Hospital and my immediate predecessor.
Hi all, yeah, I'm Tessa. As Hash said, I'm a peds ICU trainee, having previously fellowed in general peds, and I'm actually currently on maternity leave with this little small person. So we'll just be hanging out here.
Thanks, Tessa. And welcome, Remy, as well. All right, so we'll start our questions. So we've got quite a few questions to go through, but again, I please encourage you all to put in some questions. These are kind of who is it in, I guess, DIT world in terms of knowing what's going on in the field, and we're really keen to kind of get through some issues tonight. The first question I'll start with is basically question one. So within the last 12 months, the Council of Doctors in Training has been working on some resources to highlight the costs and competitions involved with specialist training in Australia. Further discussions with many trainees from various specialties are continuing to highlight the variability amongst the colleges with regards to fairness of assessment and trainee support. Panel members, what do you feel are some of the biggest issues with regards to college training programs in Australia, and how can we work together to improve the situation for trainees? Helena, I might just start with you, if that's okay. I mean, I know you're technically in the pre-vocational space and the rest of us are in the vocational space. So I kind of wanted to say, see what your thoughts are with that, with regards to this.
Yeah, I think coming from my point of my career and sort of within orthopedics, which is pretty notorious, I think one of the biggest difficulties facing junior doctors who are in the pre-vocational space is the changing goalposts of what college requirements or what their selection criteria are. So, you know, looking, I guess, within my specialty, if you have a look at what the AOA requirements are, they change year to year. You know, it's very much in trend that sometimes it'll be a focus on research, and then other times it'll be more a focus on, you know, how many positions people have held and all this, you know, leadership and all this sort of stuff. So I think that is probably the biggest area, is that it's so competitive and yet the goalposts are continuously changing, and there's sometimes not wonderful communication from the colleges about what their specific application requirements are from year to year, which I think adds a lot of stress to people who are in the process of applying to training programs. Also, you know, in that pre-vocational space of just trying to get onto training programs or during training programs, there's a huge amount of cost that's associated with people doing masters and PhDs and all of these extra courses, which count towards your application. For surgery, there's the wonderful GSSE, which is not an inexpensive exam to sit. It's got a high failure rate. In the sitting I did it, it had more than a 50% failure rate, and it's more than a $4,000 exam. So all of these courses, all of these higher degrees, all of these exams are just adding costs to people in the pre-vocational space who really, at the end of the day, there's no guarantee that they're going to get accepted onto the training program at that choice.
Thanks, Helena. Bev, I might go to you. I mean, you've, I guess, experienced a couple of different training programs, and so you kind of have an insight into these programs and I guess the differences between the different colleges. I mean, I know you unmuted Mike, so you might have another comment as well, but I just wanted to ask you about your thoughts about this question.
Yeah, and you're right. So this is actually my third college training program, and I've not finished any of the others. And I guess one of the things that the current way we do things really impacts on is your ability to try and do something, see if you actually enjoy it. You get sold a lot of things when you're a medical student. You get sold a lot of nice stories about specialties that you may or may not like. And until you get an opportunity to actually try those specialties, it becomes very difficult to make your sort of long-term career plans. Now, in all of that, because of these onerous requirements, as Helena rightfully pointed out, you have to spend a lot of money and time as well. So the minute you start spending all that money on courses, on getting further qualifications, on essentially polishing up your CV for a make or break attempt at a college training program, you get stuck into that sunken cost fallacy. You spend so much effort and time in these things that you sort of forget about, you know, what you're actually trying to do, but also you stop looking at other options that you might be interested in. And it does deter people from trying different specialties. And I think to some degree, it does lead to burnout. A lot of people put a lot of effort into these things, and there's only a limited number of vocational training positions. So in the long run, some people will be disappointed and will have to, I guess, face that disappointment in different ways. So it's not a system designed to be supportive of the current junior doctors.
Thanks, Bev. Tessa, I might hand over to you and see your thoughts.
Yeah, I guess I'm just bringing out a couple of threads of what Helena and Bev brought up already. This idea that once you're in a training program, you're kind of on the escalator. So you're on, and it doesn't feel like there's really any lateral movement option. You have to either just keep going and get to the top, or you can try and kind of like run back down, but then you've got to start again. A bit like snakes and ladders, maybe. And I guess one thing that we have previously advocated for at CPMC, so the Council of Presidents of Medical Colleges, is this idea of trying to facilitate lateral movement between training programs. I think as we get more colleges and the training programs become more defined, and I think each college and even within the colleges, the subspecialties become increasingly siloed, and it becomes increasingly rigid, the requirements that you have to meet to progress through a particular subspecialty. So I'm thinking of my training pathway. You know, I have completed general pediatrics, and then previously all you had to do was kind of get halfway through Gen Peds and you could transition to do advanced training through the RACP in intensive care. But now that we've got the College of Intensive Care Medicine, actually what you have to do is have a fellowship to be exempted from the primary exam and to progress into advanced training in intensive care. So, you know, what that has done is added sort of 3 years to that training pathway if you start in pediatrics, which a lot of the peds ICU trainees do. And I think there's similar examples in other colleges as well, where as, you know, they become more grown up, more defined and more siloed, it becomes harder to move between the different training programs. Even as Bav said, maybe there are, you know, aspects to your career or you know, a different field that you find actually you'd like to move into once you've started something else. So I think the idea of having perhaps competencies that can be recognised between different training programs would help facilitate that lateral movement, and is something that, you know, maybe we need to look at advocating for on an ongoing basis with the colleges.
Yeah, I mean, that's a great idea, Tessa. And I think same with Bob. You see a lot of trainees go through all the way through one program almost, and then they have to take a step back all the way to residency if they do change. And, you know, that's a big onus and a big decision to make in a point in your life where there are a lot of other important life decisions to be made in that, you know, period of time that doctors in training are.
And I guess just to add to that as well, you know, we have this real need for generalists, for more general practitioners and more rural generalists. And I don't think we have a good way of recognising the skills that people have gained in other roles that might, you know, be really useful to then, you know, transition into a generalist career. And again, unless we have ways of recognising the experience that they bring to those roles, then it kind of gets lost. And I think we discourage people from making the moves that we need them to best supply our workforce and our kind of communities with the professionals, the specialists that they need in the particular specialties where they're required. And like I say, I think that's particularly in those generalist fields, which are, you know, relatively undersubscribed compared to the healthcare needs.
And we are definitely going to be talking a little bit about that as well later on tonight. Maddie, I don't know if you had any other comments to make on this question.
Just, I guess, the final thing I was thinking about being from Townsville is just the fact that we need to look into how we can facilitate rural sites to further facilitate specialist training. So I think a lot of people get sort of stuck in that rut of having to be in cities to do some of these major college training programs. And if there was a little bit better support and supervision for some of our more peripheral sites, that also might open up more positions as well. Because I think, you know, just the sheer low numbers of people being able to enter year to year is one of the other major issues. But yeah, no, I think we've covered it.
Thanks, Maddie. I think, and the last thing to comment on was, I think part of the question was about costs and training, and I guess just talking about transparency of costs and training for trainees, and where, you know, trainees are having to pay sometimes tens of thousands of dollars to get onto a training program, number one, but also to complete their training program at number two. And so I think that's another consideration that we've been looking at both at the federal, I know, level, but also at the state-based level too.
Hash, yep. I guess had one comment, and perhaps this is a plug for GP training. I think Tessa might resonate a little bit with this, but both her and me are at that point of our training where we're at the tail end. And certainly a lot of my colleagues who went off and did general practice training early in the piece, a number of them are retraining now and doing other specialties. There's psychiatrists and there's surgeons, and it's a really good generalist training program, but there is an additional benefit in Queensland. By PGY4, you can be a fully fledged GP, and if you enter into another training program at that stage, you actually get paid at almost 50% more than your other registrar colleagues, according to Queensland Health Awards. So there is a monetary benefit of doing some of these things in a different way. So just a little you know, plug for doing GP training first.
Just to say, in New South Wales, there is no such benefit. I think I get, for having a fellowship in a college, I get $50 a week or possibly a fortnight for a higher qualification allowance. So I think it's very state dependent how well recognised those other experiences are. That's
right. You heard it first. Queensland has a great reward for DIT. So we'll try and help you out in New South Wales. All right, moving along. So our second question, it is clear that specialist medical training and the medical training pipeline in Australia is facing a crisis. And we have all heard the terms medical student tsunami and the lost and ever-growing pre-vocational tribe. Panelists, what do you see as the main issues contributing to the blockages in the medical training pipeline? And how do you think we can address this? So now, Tessa, you've got a lot of experience in the national sphere, and particularly around the National Medical Workforce Strategy. So I might hand over to you first, and then we'll hear the opinion of the other special training panelists, sorry.
Yeah, sure. Thanks, Ash. So I guess as you've highlighted, there was a huge increase in the number of medical graduates in sort of the second half of the first decade of this millennium. That's a weird way to put it, but kind of like from 20 2005 to 2010. It's like 120% increase in medical grads. Training positions, college training positions didn't expand by that much. Some have grown, some haven't. And what we've seen is because we've got this oversupply of medical graduates compared to the training positions that existed and continue to exist, there's a mismatch. And then there's also a mismatch between those training positions and the community need for specialists at the end of the day. So as I flagged before, like roughly we think about half of our medical graduates need to be general practitioners to kind of have the right balance of GP and non-GP specialists at the end of the day. But actually in medical school, there's a huge interest in general practice. But I think what happens is that once we start our internship and residency, our generalist years are actually a series of subspecialty terms, primarily in tertiary hospitals, although there are growing and improving experiences in a lot of our regional centres, which is awesome, and that should, I think, really be expanded upon. But you spend a lot of time doing these subspecialty terms, learning about like vascular surgery and I don't know, the immunology of the eye and all this really kind of cool, interesting stuff. But at the end of the day, you don't need that many people to be specialists in that area. What you need is a lot of excellent generalists with some stretch skills and sort of subspecialty interests, not only to kind of meet community need, particularly in regional and rural areas, but also so that you've got some flexibility in your workforce, so that as sort of demographics change or healthcare needs change, you don't just have, for example, at a hospital, say you need to run a general trauma service in like a sort of a secondary or smaller tertiary site, but manning that trauma service, an example given by one of the old RACS presidents was that they had like a vascular surgeon and a upper GI and a lower GI and all these very subspecialized surgeons that couldn't actually comfortably fill that generalist surgical role to be on call for all of the sort of general trauma stuff that might come in. So that loss of generalism in favour of subspecialisation, I think, begins with the way that we get our exposures in our internship and residency. And I think we need to look at ways of better aligning the experience of pre-vocational doctors with the kind of breadth and with a greater emphasis on generalist skills, and making sure that we actually experience community practice and subacute care, which actually a lot of people are really interested in if they have the chance to experience it. But you can't kind of pick a specialty that you haven't really seen, and that's something I think Bav raised before. So the other thing is, I guess, just to quickly raise that there's this maldistribution between trainees, not just between metropolitan and rural areas, but between specialties. And part of that is driven by the fact that some colleges have very constrained, controlled trainee numbers, and others, more like, say, physician training and until recently emergency medicine training, was just get a job and then you're a trainee. ICU is sort of somewhere in between from my experience. And I think what we're seeing now is that the specialties that had like uncontrolled trainee numbers that were determined purely by how many registrars a hospital service needs are now in relative oversupply. And so we're seeing real blockages, for example, in physician advanced training at that part of the pipeline, and also in emergency medicine, the exit block, where you've got, more than, I think it's 2 times the number of trainees that you have as you have consultants. And so that's concerning. So all of those things I think need to be rejigged, and that's in large part what the National Medical Workforce Strategy is aimed to do, to try and measure community need better, which we haven't really tried to do in a kind of coordinated fashion nationally to date, even though most of our training programs are national, and to then match the specialty training program places with that community need, and to make sure that everything that helps determine our decision making, as Prevox in particular, helps kind of guide us into the specialties that are actually required by our community at the end of the day. I'll leave that there.
Thanks, Tessa. And I guess just to highlight the point of the National Medical Workforce Strategy, so that is part of the solution that we hope, and doctors in training are obviously contributing to that heavily as well. I might go to some of the other panelists. I guess Helen or Bav or Maddie, do you guys have any comments to make on, I guess, the maldistribution or regional maldistribution in trainees? Maddie, I might go to you next.
Yeah, I was just going to say, I think Tessa's absolutely right. When we go into medical school, we see all these subspecialties, and then straight away in internship, again, we're in that hospital setting exclusively. And every single question you get from everyone is, what specialty are you going to choose? Almost every week you get asked that question. I think there's such a cultural problem as well that just pushes people into streaming so early, to the point where, you know, people are trying to get very specialized rotations even in their internship. And we lose that sense of generalism. I myself even didn't even do a normal general surgical rotation. I did neurosurgery. So I'm even a byproduct of this poor problem. And so I think if that's one of the things culturally we can do amongst our own hospitals and with each other, is just sort of to take that pressure off of junior doctors entering the workforce and allow them to just take that time to figure out where their interests lie and what might work for their lifestyle and what they want to do going forward.
Thanks, Maddie. Helena or Bab?
I've got, I guess, a brief comment on just pulling something that Tessa said previously into a bit more detail about the physician trainees and the ED trainees. I guess one of the things you see is, because we start letting or relying on colleges to regulate training positions, and in those two instances, they're very poorly regulated. So if you pay your fees and you send in your application form and you find a job, you're a trainee and you're on your way to fellowship, is we create hospital systems, and this is me wearing my administration hat, but you do create hospital systems that rely on that workforce. So we've got this weird situation in Queensland at the moment, where we are undersupplied for advanced physician trainees and ED trainees, and there are hospitals that are in desperate need of those and paying locums a lot of money. But the minute they become consultants, we don't need them anymore. They're too expensive, they're an oversupply. You'll be stretched to get a job even in regional Queensland in some of these specialties. So it just seems odd that we need one part of that pipeline and not another. So we clearly haven't got the pipeline right, or we haven't got the escalator right that these people get on, because there's no jobs for them at the other end. And that's the frank truth of it. So unless you're planning on being a 0.2 FTE ED physician and also do other things on the side, it's going to be very difficult for a lot of the current trainees to find meaningful employment on the other side. So I think that's something we have to look at and be wary of. And the other thing is, on a slightly different point, I think sometimes we undersell ourselves or our value as junior doctors, because we get stuck into this thing in various states. There'll be different awards, but in Queensland, in our award, where this is how much we get paid, and you work your way up to the other end to get paid a bit more. And I think we often forget that in an open market system, you know, the value of a junior doctor is determined by what we pay our locums. And so we get stuck thinking that, you know, maybe this is what we're worth. And we don't all need to be consultants to earn a livable wage. And so, you know, when we talk about the value of pre-vocational doctors, we shouldn't just be looking at what the hospitals pay us, but looking at what we're worth in the open market. Just a thought.
No, definitely. And I think, and Tessa may have some more insights, but that the first issue you talked about, which is over-reliance on registrars, is a key feature of the National Medical Workforce Strategy, because that's pretty much what you're talking about, Bav. Workforce needs are demanding and driving, I guess, the output of consultant specialists who are graduating. And so there's obviously this imbalance that's going on. Tessa, yeah?
I was just going to say really briefly, yeah, it's really interesting that over-reliance on registrars, like even in the 10 years that I've been a DIT, that's depressing to say, I've seen so many services change from being like PGY to 24-hour cover with a registrar during the day, say, to having 24-hour registrar cover. And I mean, I don't know if that's purely a pediatric phenomenon, it'd be interesting, but I suspect that that's being driven in other specialties as well. And a lot of it is kind of a risk aversion thing. Like everybody wants to have more senior trainees who can, you know, run the Met call, who can attend the neonatal resus, do all of those things. But like you say, Bab, there's no place for them to be consultants at the end of the day. And yet we're particularly in the training programs where there's unconstrained trainee numbers. By creating more posts, you're creating more trainees. That said, the flip side of that is if you do have a college training program where the trainee numbers are constrained by the college, not sort of by the, you know, employment opportunities, then you end up with a large unaccredited pull, and this is, you know, really the issue, in particularly in surgical and obstetric and gynae, you know, training among others. But increasingly, it's going to be, you know, other colleges as well. Like ED has changed to be more accredited and unaccredited training now, which is totally new. And so, you know, that's the flip side. That then, well, what's worse? You know, where do you want your pipeline block and your potential kind of purgatory period to be? Do you want it in that pre-vocational training space when arguably you're still a bit more pluripotent and you can maybe differentiate into another specialty kind of, or a specialty trainee if you don't get onto your chosen program? Or do you want to get all the way through your program? And then, yeah, maybe you can move overseas and stuff, but by that point you've put down more roots, you've got more, you know, really invested in being a specialist in that field. It's harder to transition, as we said before, because it's not really that there are that many recognised competencies between specialist training programs. So I think it's really critical that we have this medical workforce strategy and we try and line up the inputs and the outputs better, because otherwise you get stuck at some point and it's kind of pick your poison where that blockage is going to be.
Definitely. Thanks, Tessa. Helena?
Yeah, I certainly agree with what Tessa was just saying, that I think one thing that's really interesting is, depending on the various specialties, where the oversupply is. So if you look at something like orthopedics, for example, I mean, orthopedics is essentially run by PHOs, and there's a huge reliance on unaccredited registrars, and you could put your hand up at, you know, quite a few hospitals around Queensland, some in Brisbane, saying that you were interested and they would just step you up as, you know, a PGY2. Yet, you know, in 6 years down the track, you may potentially be in a position where you're never going to get accepted onto the training program. So the maldistribution or the oversupply of within specific specialties, as Tess was saying, I think is really interesting compared to something like the emergency department colleges, where you can say you're interested, you become a trainee, and then on the other end you're struggling to find a consultant position. I think that kind of ties nicely back into what we were saying before about the pressure or the stress of getting onto specialist training programs, and sort of the CV race it's becoming, or for a lot of specialties. But I think it also highlights the need to have for there to be a cultural change, but also to try and make incentives for people to stay as non-specialists or to go into general practice. And as Maddie was saying before, I think that requires a really big cultural shift. Certainly within my experience, and it's only been 3 years working in the hospital, I think, as Maddie was saying, it's always like, oh, what are you going to specialize in? And you never have, I think the majority of people I know, my own experiences is that you are interested in specialties that you have worked in or that you've been a medical student in, and you've had really positive experiences. If you're a medical student, you only do one 7-week term in GP. It's hit or miss depending on what practice you go to. And if that's the only GP exposure you ever get, why would you want to go into GP training if you then start your internship, you're working on the HPB ward, hepatobiliary ward, and that's the only surgical experience you get. It's I think it's all about changing people's culture, making it a normal thing that people can exit after 2 years, that's okay to go and try GP training. If they don't like it, then there's an exit path for that, for people to come back and be a junior doctor again. But at the same time, that there's appropriate exit pathways for people who get further along that career, 6 or 7 years working as an unaccredited registrar, and then being able to exit appropriately and get accreditation for the work that they've done and recognition for that work.
Yeah. Maddie, did you have something else to add?
Yeah, just the last thing I was going to say, I know the National Medical Workforce Strategy is a big part of trying to combat this problem, and ongoing sort of working with the colleges and the College Trainees Forum. But I think the other thing that's sort of a part of the solution is making that pre-vocational time worthwhile for people's training and education as well, and making that more of an accredited space with one of the postgraduate medical councils, so that people are actually getting protection, they're getting a bit of teaching and education and time to do professional development and things like that, rather than just being, you know, chucked onto 2 or 3 relieving terms in the year, or put into those service registrar roles where they're not actually learning and growing their skills whilst trying to decide which direction to go in. So I think that's probably another key part of the solution for this.
Yeah, I'll wrap up this question by agreeing with everyone on the panel, of course, and just realizing that it's not really, I guess, the setting itself, but the quality of the experience that a junior doctor has in that space. And that's where accreditation comes in, because, well, it should at least ensure that the experience that whatever that trainee or pre-rock is in is getting the quality training they need to make, I guess, a decision about what career they want to go through. And I guess aids them to perform whatever generalist experience they have. And this is where the AMC review of the intern space is looking towards. As Tessa mentioned, it's important for all trainees, no matter what field you get into, to have kind of some understanding of what acute, subacute, chronic illness care and community care is, because again, that's going to make you a doctor who's able to look after the patient with multiple comorbidities, and that is both falls into all those places. So I think that's where the AMC review is going to. And I guess the other thing is that we're really advocating for is accreditation of all the pre-vocational space to make sure that these issues are being encompassed for trainees. All right, moving on. The next question is directed at Bav, but I'll get everyone else. As the administrator in the room, I might ask him this question first. But often we hear our consultants and seniors within the healthcare sector frustrated by the disconnect between delivering clinical care and meeting administration KPIs. Do you feel like junior doctors experience similar frustrations, and is there a disconnect within our hospitals between administration, consultant and DIT, and how we can bridge these gaps? Sorry to put you on the spot.
Yeah, no, look, it's a question that's got quite a lot in it, because I think as everyone here and probably everyone listening has gone through, you've been on the ward and you've heard that, oh, we've got 20% discharge summaries completed, we need to do more. And I think oftentimes when we're junior doctors on the wards doing that sort of work, we sit there and go, oh, that's useful, but I just started today on this new rotation, and so I have nothing to do with those uncompleted discharge summaries, never looked after them. I'm looking after 4 teams and all of those sorts of things. And there's a disconnect between the metrics that we are held to account to, or try to held accountable for rather, and the metrics that perhaps we have the ability to control. Some of that's historical. Some of the ways that hospitals measure things, we know it's not perfect, but it's the best that they can do. So if you take the attitude perhaps that let's assume in good faith that the discharge summary is the best communication tool for the patient's care outside of the hospital back to the GP. We know that's not the case. There's evidence to suggest that these days, but let's assume that's the case. Then this becomes a metric that the hospital's interested in the interest of patient safety. Now, another thing that the hospitals might use a discharge summary for is actually coding. So by utilizing an adequately or properly timely completed discharge summary, you potentially can generate more income. Now, in good faith, let's assume that income comes back to that department to use to benefit the team. We know that's not always the case, but in those instances, I think you'll be able to see those benefits returning by that timely completion. So when everything works well, these metrics make sense. Oftentimes, what happens is there's pressure put on managers to meet KPIs that don't necessarily make sense to them, and then there's no ownership of those KPIs. So if I'm a junior doctor on a ward and my director of training is saying you need to achieve all of these things for the hospital, that's always going to be second tier to what I want to achieve for my patients, and then what I want to achieve for my training. And if there's a hospital that says we're not going to pay you overtime for discharge summaries, and that happens in a lot of places, then there'll be an incentive not to complete those adequately or in a complete manner, which helps achieve the actual intent of the KPI. So you want a good quality discharge summary for patient safety and for funding. But if you just write a 2-sentence summary to get it done, that doesn't achieve it, but it meets the KPI. So I think it's often a bit disheartening to see the way these things evolve over time. But there are times when I think we have to go back to bad outcome measures and why we bother doing that. And this kind of talks the reason why we need more doctors in leadership positions. I, for example, in my department at Logan, tell every resident walks in at the start of their term and every registrar that we pay all overtime. No questions asked, we pay it. But what I do is I monitor it and I look at where the pain points are. I look at the rosters and I try and see where we can adjust rosters in a fair way to reduce the fatigue on our doctors. Now, we don't have any fatigue because we've managed to do that in an effective way, but we do pay overtime. Now, unless people claim the overtime that they work, it's very hard for a department to do that. Now, there could be cultural reasons you don't do that, and I understand that. In a perfect system, in a perfect world, that's how it's supposed to work. And the system is designed on a perfect basis, but obviously not run by perfect people, and no one's perfect. So I guess another brief point, I guess, on that is for so long we've measured things like metrics and discharge rates and length of stays and all of these things where we traditionally thought they impact or they show how well a hospital is performing. We know that now there's a lot of work on value-based healthcare, and the whole idea of it is to put the patient in the center of everything that we do and try and improve their experience and the outcomes. So in an obstetric department, the metrics I measure might be infection rates in a cesarean section and those sorts of things. But the actual woman's interested in when she can return to work, how long she can't lift heavy things for, and all of those sorts of things. So we might pat ourselves on the back because our infection rate's lower than the rest of the state, but she might be at home quite anxious and concerned about her economic situation. So there are things that we don't do well and we need to improve, but there are also things that we don't measure well that we don't need to.
No, great insights. Thanks, Bav. I mean, it's useful having you here on the panel to give us that kind of administration perspective, because we as doctors in training rarely get insight into that. So thank you. I might move on to the rest of the panel members, I guess, from a doctor in training perspective. I know there's lots of discussions about administration tasks for junior doctors and doctors in training and what your thoughts are on that. Maddie, might go to you first if you like.
Yeah, I've got, there was one time I was on cardiology as a resident and I was faxing off some referral forms and the boss kind of walked up and said, "Oh, what are you doing?" And I said, "Just sending off the referrals." And he was in utter shock that he thought the administration officers usually did all of that and that we didn't have to fill out that pile of paperwork. And I just wanted to laugh and cry at the same time because that's 90% of that job. And so like, I do feel like sometimes there is a bit of a disconnect, and I think that sort of grows at each step from sort of intern to registrar to consultant and then to department directors and EDMSs as well. I think that, one of the solutions is to, like Bav said, is get more junior doctors into these leadership roles and get people who are actually doing these jobs around the table, so that we can have conversations and come up with innovative solutions that will work on the ground, sort of at the coalface, as it were, to actually sort of help get through the tasks we need to do in a timely manner, but also have them happen in that patient-centered way.
I think the first step is probably getting rid of fax machines, but who knows? Helena, I might hand over to you next.
Yeah, I completely agree with what Bav and Maddie have said. I do think that a disconnect exists, or can sometimes exist between junior doctors and consultants about actually sort of how much paperwork and admin work can form part of the intern and resident job. Again, sort of as we were talking about before, I think it all sort of links in, because I think when people feel overwhelmed in a busy term where there's 1,000 discharge summaries to get done, then it changes people's perception of that specialty, and that it really influences whether or not a specialty has a positive or a negative reputation. So, certainly there are specialties or rotations where it's much more work or admin heavy than other rotations, which may be a little bit more hands-on. For example, emergency department, which is a really great intern rotation compared to someone who's on their surge or med rotation, which might have more discharge summaries and writing, about 50, tonsillectomy discharge summaries, which all aren't particularly difficult and don't really range. So it's all about, I think it's about trying to redistribute, monitor the appropriate amount of admin work that junior doctors are getting exposed to, while acknowledging that it's important and it's all about the overall success of the hospital and being a team player. But at the same time, it's important about making sure that our interns and our residents stay engaged and are learning. They're not just sitting at the computers churning out tonsillectomy discharge summaries.
I agree. Tessa, is anything different in New South Wales?
Nah, same problems world over. I guess I think some of the insights that Bav had have been, really, really nice, to the idea that we really do need more doctors as leaders, because I think that really helps drive engagement. Because one of the points he made was that it's so much, there's so much importance to knowing why you're doing something, knowing the purpose of it, and when you do a task that you have some sort of ownership over it, and that you, sorry, noisy little baby doing what he does best down there. Anyway, so I think that there's a lot of importance to be put in understanding why you're doing something, having ownership over it, and there being essentially engagement of clinicians to sort of buy into some of those more administrative tasks. And the best way to achieve that is I think to have some people in administrative leadership positions who are clinicians, and can act as that conduit sort of between the hospital interests and the clinicians' needs, and really foster a mutual understanding. It's when it feels like there's a big disconnect between those above and the bean counters and everything else, and you kind of want to shake your fist at the sky at these people that sit in the administrative land and clearly don't understand what we do, when actually that's not always the case. So I think any opportunity to kind of connect and realize that it's all people with ultimately the same goals in mind, which is the best kind of patient care that we can provide, is something that we should sort of strive towards. But that's appreciably very difficult in sort of busy, resource constrained environments, which many of our hospitals are.
Yeah, thanks.
Can I just say, doctors don't get trained to be managers. We are expected to be leaders. And I think, so college training programs like RACMA are a good example where you actually get trained how to manage teams and manage people. And it's a vastly different skill. Just because you're a good surgeon or a good pediatrician doesn't necessarily make you a good manager. And you could be a great leader. You could be in all the AMA positions in the world, but doesn't again mean you can manage people. And that's one of the humbling things that I've learned over the last 2 years I've been in medical administration. So.
Bav, do you think there's things that are in the RACMA program that really need to be in all college training programs?
I think medical management and leadership has to actually start at medical school. You need to start with clinical governance. You need to talk about quality and safety, and that the whole idea of why we do this and how we continue to improve, and then that leads into management. And I think there's different aspects of what we do in RACMA training that absolutely need to be core curriculum in a lot of things. Some colleges do it better than others, but a lot of them talk about leadership, not necessarily management. And we expect doctors, especially once you go to private practice, and there's a lot to do, to go out and become small business owners overnight. And a lot of these practices fail because they're not managers. They're good clinicians, they're not managers. So absolutely, at all levels.
Yeah, very good insights, and I think I completely agree. I mean, we all see, I guess, doctors in these positions of leadership, and we're all leaders in some way, whether that be at a Met call to that level, or whether it be the department head in some level. We're all taking leadership roles within the health system, and I think you're right, Bav, and I think it needs to be built in more at the medical student level, at the pre-voc level, and also in the college training programs more broadly. And that's something we can definitely discuss further through our advocacy at CDT level. The next question is about the AMA Queensland Resident Hospital Health Check, which of course has identified the payment of overtime as a concern for junior doctors in our state. Issues such as access to professional development, annual and parental leave, as well as unpaid overtime have continuously been raised in the issue for several years, which we've mentioned already. I guess, panel, what are some of the factors contributing to this continued systemic underpayment of junior doctors, and what steps have been made to improve working conditions for DITs? Maddie, I might go to you first as the chair of AMA QCDT, and your thoughts on the results from last year's survey. And of course, we've got this year's survey coming up soon.
Yeah, look, I think, you know, this issue has been raised every year, and probably has been long before I was in medical school. And I think, you know, there's lots of multifactorial issues that crop up at every meeting we have. We've got a hospital rep at every site, and there's always some sort of industrial issue around overtime being claimed and things like that. And some of it can be just technical issues, so difficulty with pay slips or payroll, not processing your hours correctly. There seems to be a bit of an excess of paperwork sometimes with claiming overtime, and as well, we've seen that with my HR has sort of increased some of the difficulty in actually claiming your overtime. There's a lot of cultural issues, as Bab mentioned before. You know, a lot of junior doctors feel like they might be looked on poorly by their seniors, or it might hurt their chances of getting onto a particular program should they claim. And then I think there's also just a shortage of other doctors around sometimes, as you know, teams are understaffed, and that's why people are working longer hours. And there's also a difficulty in securing leave. So I know a lot of hospitals do have a bit of trouble trying to secure that professional development leave that we've got allowances for in the MOCA, because there's just no relievers available. So I think there are a lot of issues contributing this. Obviously, budget's one of the things that could change to fix that, but that's always difficult to have that changed. I think it's one of those things, like we've been talking about before, is having more doctors in training sort of at the table and discussing with their managers what things need to change, and being a voice for change within your own department. You know, what things could be optimized, what suggestions do you have to try and reduce the amount of work that's there, or make sure it's done sort of within the allotted time frame, so that you're not sort of sitting around at 10 o'clock at night.
Bav, did you have something to comment on?
Absolutely. I love this discussion topic, mainly because it's been going around for years and years. Ever since we did the first resident hospital health check, we've known this has been an issue on a numbers level, but it's been an issue for a lot longer. Let's just call it what it is. It's actually just wage theft. When we don't pay doctors the hours that they work in looking after their patients holistically, it's wage theft, like any other specialty, in like any other job or anything else. Now, it's funny because going back to the medical administration side of things, overtime is actually something we budget for in our departments. And it's budgeted on the basis of what the average overtime was the year before. So if we have a culture of telling people not to claim overtime, we'll never fix the problem, because the subsequent year will look like we are doing more than we need to. So every year on year, we're readjusting how much overtime budgets are. And so if you don't claim it, you're not just doing yourself a disservice, you're actually doing a disservice to the people who come after you. At the end of the day, it's a number on a screen, and it actually improves the quality of your peers below you as well. So if that's the only thing I can say, then claim your overtime, please. The funny thing to follow on from that is something like maternity leave is not budgeted. So despite over half of our doctors, especially doctors in training, being female, we don't budget for maternity leave. And also the biggest other workforce in health, nurses, being predominantly female, again, it's not budgeted. So if I was a manager, which I am at the moment, and I've got a number of my doctors who may go on maternity leave, because I work in ONG, and most obstetric registrars at the moment are females. If some of them go on maternity leave, I might not be able to backfill them if I don't have budget for that. Now, in a bigger scheme of things, other people may choose to go, why should I hire a female if there's a male that's equal on par or considered on par, because they're not going to go on maternity leave. So I think it actually causes discrimination when we don't have accounting that allows for maternity leave. Surely we can predict that at a HHS level and at a state level. So it's one of those things that's so ingrained, and we talk about equity and we talk about allowing for women to return to the workforce. well, how do you do that when you have discriminatory policies at that level? So essentially we're saying, don't be female, don't go on maternity leave, and we might hire you next year potentially because you've caused a lot of disruption to the department because you've gone away for 6 months or a year. Now, I'd like to think people don't do that, but I can guarantee it's probably happening somewhere in Queensland right now.
Thanks, Bab. I might pass it on to Tessa, because I know you've done a lot of work in medical parents in training and talking about discrimination, I guess, in the workforce for female trainees in particular, but for both genders, I guess, is what we're kind of talking about. What are your thoughts, Tessa?
Yeah, so just to echo that this is an example of systemic discrimination, but by that I mean it's the system that is discriminating against trainees who want to take parental leave. Primarily that's women taking maternity leave, which tends to be a little bit less negotiable than non-birth parents wanting to take parental leave. Be that kind of fathers in hetero relationships or same-sex partners, and adoptive parents are usually better kind of covered in our wards, but certainly the non-birth parent doesn't tend in the majority of our industrial instruments to have much have many rights to sort of paid leave and to have that need for leave to go and parent a child to be valued. So I guess I've done some work in New South Wales and also federally, and I think it's really important that we think about what we need to do to improve the situation. And I see that there are so many systemic elements to this, everything from the way that it's put into the budget spreadsheet. So for example, in all of our departments in New South Wales, maternity leave comes out of the department, not from the health district or like a general health department pot. And what that means is if you've got a small department, say you've got 1 or 2 advanced trainees, your trainee goes on maternity leave, cool, they're entitled to their paid leave. But then you have an actual problem. How do you backfill that position if you don't have the budget for it, as Bab said? So a really practical thing we can do to try and, remove the situations where even though they know and maybe they don't even want in their heart, to be discriminating against female trainees, but you have heads of department or recruiters being sat in an interview room with trainees and going, I need my department to be staffed. Otherwise I literally can't, run my clinics, perform the procedures that, my patients, my community needs. So they're put in this awful position where, despite best intentions, I think there's a lot of potential for discrimination to arise if they see a pregnant trainee walking in. We all know that there have been, inappropriate questions asked in interview situations. Oh, what are your plans for this year? Is there any reason you might not see out your contract with us? All of these kind of veiled reasons, or veiled ways of asking about, leave plans, down to many more downright kind of examples of like, so, are you going to be pregnant, or, so that you're aware, no leave will be permitted in this contract, this kind of stuff. So there's a lot of I think, unintended as well as, more and more nastily intended discrimination in the system, but we really do have to look at what the drivers are in the sort of the way the system's designed before we can even hope to change culture.
Thanks, Tessa. I'll move on. I guess we're talking about some big issues here. I guess mental health and wellbeing is another huge issue that has been highlighted recently by COVID, and I do want to leave one last I guess, question to COVID as well, specifically given it's something that we're all facing at the moment. But I guess bullying and harassment is a large part of the systemic issue for mental health and wellbeing, with 40% of DITs in our state reporting that they witnessed bullying and harassment in our last Western Hospital health check. It also should be noted that the 2019 medical training survey the board has just re-released again this year has reported that more than 1 in 4 DITs are working more than expected, and this has impacted on their well-being all or most of the time. I guess all of these situations are leading to the risk of burnout and mental health, which we've known for some time, and we're, I guess, all trying to figure out what the best way to improve well-being is. And I think some of us know that it's systemic issues really, rather than individual factors only, that are causing these problems. I guess, what are the panel's views on what needs to be done to improve the well-being of junior doctors and prevent further losses of life? Because we've unfortunately had quite a few string around the country and in Queensland as well. I'm going to go to you, Maddie, as well first, if that's okay.
Yeah, I mean, this is certainly at Townsville specifically, we've had 3 either doctors or students suicide this year alone, which has had a huge impact on everyone. I think that, this is obviously something that was highlighted several years ago with the Beyond Blue survey, and there's been a lot of work and discussion around this since then, which is certainly a good step in the right direction. But I think that when we looked at the AMA's position statement on doctors' health and wellbeing last year, it was very clear that there's a lot of onus on what doctors should be doing for themselves. So there's a lot of messaging about, getting your own GP and doing your own mindfulness techniques and making sure you sleep enough and you exercise enough, all of which are excellent points and very important. However, I think there's always been a bit of difficulty in challenging some of the systemic issues that contribute to poor mental health and wellbeing amongst doctors. And those are things like overtime and being in a service registrar position and feel like you're coming up against a wall when you're trying to progress your career. I think, there's issues around inadequate parental leave, and we've seen that from a number of people, having their families really sort of almost torn apart over not being able to get a leave. And I think, it's these sorts of systemic issues that we need to, again, have more doctors discussing things around the table with their leaders, with their administration teams, and highlighting, where can we tweak things within the system to still provide the care we need for patients, but also make sure that we keep our workforce safe and healthy.
Thanks, Maddie. I'll ask Helena, I guess the pre-vocational space is quite a stressful space trying to get onto training programs. How do you think that affects the well-being of junior doctors or doctors in training?
Yeah, I think certainly the career uncertainty that all, doctors who are generally high-performing people, it certainly increases or is a contributor to why there's such issues with health and wellbeing in junior doctors. As Maddie was saying, I think something that I find quite interesting is how when there's a suicide or when people are talking about mental health within junior doctors, it always seems to fall, the burden seems to fall on the individual seeking help, and the individual going to the GP, or the individual realizing that they are experiencing burnout and trying to practice mindfulness techniques or resilience on the run. But I think we need to sort of think about the other elements of that. And, I guess this year, when we've had a few suicide attempts, it's made us really look at what support is directly available to junior doctors who may be struggling. And that doesn't need to necessarily be with their mental health. It may be genuinely struggling clinically, settling into intern life or changing rotations. And the pressure points that we know exist within an intern. If we think of the intern's life over their year, we know that stress increases at the time of new rotations, or at the time of big surgical increases, pre-Christmas, or towards the end of rotation when assessments coming up. And so I think there really needs to be more work done in the space of medical education units, having really promoting services that are available to their junior doctors, and highlighting the importance of them being confidential, highlighting the importance that it doesn't impact your assessment or your ability to get re-employed the next year, highlighting the importance that you can take time off, and while there may not be a whole lot of fat in the system, the work will get done, and it's okay for you to take 1 or 2 days off if you are genuinely fatigued and not have to feel stressed about it or feel like you're burdening your colleagues. So I think there's a lot. I didn't really particularly answer your question, Hash. I think in the junior doctors, we face a lot of particular stresses. Career progression and getting onto training programs is one very small part of it.
Tessa and Bav, any further comments? I guess, It is a huge topic, and I mean, I know we're running out of time, but I think, you know, it's hard to encompass this all in like a couple of minutes. But Bab, did you have any final comments?
I guess it's really, look after yourself before you look after others. And as we saw in the early days, it almost seems like a lifetime ago of when COVID first came to our shores. There was a poor GP in Victoria who got dragged through the coals and vilified for doing what he thought was appropriate. And so, that whole attitude that we've always had as doctors of, not taking sick days because it's going to put our colleagues in workloads up. I think we have to move away from that, especially now, and go, think about yourself, because if you're that doctor now, you might find yourself unemployed for a very long time. So just look after yourselves, take time off if you need it. The system will survive despite or with you.
Thanks, Bab. And I guess for anyone out there who is needing support, I guess, we have the Doctors Health Advisory Service Queensland, or the Queensland Doctors Program here in Queensland, but nationally as well. There are services available, and I obviously recommend you talk to your GP. And if you have friends out there, just tap them on the shoulder and ask, are you okay? And there are, obviously that movement that's going around as well. So I think we can all have a part to play in this. So last question for the panel, and I think we'll have to limit to a couple of minutes each, if that's okay. And again, this is a huge topic, and again, I apologize for, I guess, my bad timekeeping. But I mean, a webinar in 2020 wouldn't be possible without talking about something of COVID-19. And I think it's an issue that has impacted us all in some way or another. And our thoughts are currently, of course, with our Victorian colleagues. I guess there's been many changes in the ways we as doctors in training deliver healthcare, and there's been significant impacts to our education and training. Panel, can you share with us your thoughts on the major impacts that the coronavirus pandemic has had on us as doctors in training? I might go to Tessa, you first, if that's all right.
Yeah, I think it's obviously the topic that you can't, as you say, Hash, you can't but address at any teleconference, and frankly, that's why we're doing all these teleconferences. Obviously, there's been a very variable impact depending where in the country you are, what kind of training program you've been in, and therefore, how much exposure you've had to not just COVID patients, but the planning and the preparation that I think overwhelmed many of us in the sort of first weeks of it. Obviously now is the period where we're actually clinically having to deal with it in Victoria, and to a much lesser extent sort of in New South Wales. We've had little clusters. I think the couple of points I just wanted to raise was how interesting I think it's been seeing how quickly the health system can change, seeing a system that when we ask it for other changes that we think are reasonable, and fax machines, payment of overtime, changes to the way that things are budgeted for parental leave, or whatever it is, sensible changes, how difficult they seem to achieve. In fact, remote education is something that I have often, asked about in my clinical rotations. And it's like, oh, it's too hard. No, we really need you to come in. Working from home was like, oh, definitely not. Like, I've explicitly been told that when I was traveling like an hour and a half to work to not have any, face-to-face clinical time. I was literally just sitting there to type reports that were in my email. So I was like, why can't I do this at home? Everything's changed. And I guess I just want to flag that I think we need to capitalize on that and realize that as much kind of difficulty and hardship, particularly that's being faced in Victoria, from a clinical point of view, from a systems point of view, what an opportunity this is to see what we can do when we have to. And I think that's quite astounding. Anyway, so that's the first point I wanted to make. Obviously, it was all quite sort of scary when it all was kind of kicking off, and I'm sure many of us are in departments like I was in the ICU where we're making, disaster plans to take adult patients, while our nurses are kind of being, suddenly having to train in sort of adult cares, because many of them have only ever looked after pediatric patients. The buying of ventilators, the rationing of hand sanitizer, whether we're all wearing masks or not, the 7 emails a day that I'm sure we're all getting about the changing conditions. Certainly in New South Wales, although we're, in no way being impacted clinically like Victoria is now, that, we're sort of on that brink, and it's at that point where things could be fine or could go horribly wrong. And I think that's, put a huge amount of stress on trainees, compounding what is already a stressful period. And I think it's also shown how brittle our workforce and our training structures can be, or how rigid we think that they are, and that they are in many ways. For example, the very fixed timelines between, say, sequential exams that need to be met have been completely thrown out the window. That's obviously caused a huge amount of stress for trainees whose exams are being cancelled, postponed, actually rescheduled after they thought they were going to be cancelled. There's been huge disruption. And yet I think we've managed to meet it with flexibility, from the JMO workforce. So again, while there is a huge amount of stress out there, I think it's wonderful to acknowledge the strength and the flexibility that I think our JMO workforce has shown. And while, like I say, it's impacted, different groups in different areas and specialties in very variable ways, hopefully I think we need to focus on what can we, change for the better to get out of this. Let's make, all our remote education remotely available on an ongoing basis. I've got to say, being on mat leave, I'm really loving being able to Zoom back into some of our departmental teaching and things, and college teaching, which has only existed in an online format because of COVID. I think, the ability to have exams in different times, or maybe more rounds of exams within a year, would be a great thing to do. And also just more generally saying, change is possible in a short period of time if you wish it to be. So that's what I'm trying to take as the potential positives out of this crazy pandemic.
Thanks, Tessa. And I think that's really insightful, because I think, there are some positives that have come from it, of course. And I think it's important that we hopefully can continue those positives post-COVID as well. Bav, I might hand it over to you as, I guess, a medical administrator and trainee in that college. I guess, what are your thoughts on COVID-19 and the impacts on training?
Oh, look, I think from my perspective, it's been a great learning opportunity for me. I was involved in responses in the Darling Downs, and then now in Logan, and now a little mini blip that's happened over the last few weeks in Queensland, and the response to that. And I think it shows our great capability to be able to change, and our ability to be flexible when the needs arise. And just following on from what Tessa was saying, I think, sometimes it's very difficult to get momentum to change things in the health system, but we've shown that it can be done. I mean, yes, it's taken a worldwide pandemic, but hopefully we can learn things from that, and that's broken that sort of glass ceiling. And so we can start looking at change in a systemic way going forward. We're not over this yet. I think there's so much that is we're yet to fully acknowledge and realize the impacts on training, on welfare. We've had a whole bunch of people affected, junior doctors affected by their partners losing work, and the fears over putting their families at risk when they're working in COVID-prone areas. And I just feel for everyone in Victoria, New South Wales at the moment with what's going on in those states. But I think there's a lot of psychological issues that are yet to surface with COVID, and I suspect that the impacts on training is going to be very difficult to count. So I guess it's an evolving space. Fill out your national training survey, because that's one of the ways we can really capture what's going on with your training at the moment. It's part of your medical board registration. Do it. It takes 10 minutes, and help us get that data.
Thanks, Bav. Great insights. I'll pass it on to Helena.
Yeah, I just wanted to echo the point that Tessa made before. I think something I've been really interested in during coronavirus is the shift of education towards interns and resident medical officers, from being traditional teaching methods of you attend teaching from 12 to 1, and if you are busy on the ward, too bad, you don't get teaching, and you should be handing your pages in, and if that's just feasibly not possible, because heaven forbid you might be working a night shift, then you miss out on education for however many weeks, to now really looking at alternative types of teaching methods and relying on telehealth and relying on less traditional forms like teaching on ward rounds, and because you're trying to fill a deficit of where someone gave a semi-useful teaching session 1 hour for 1 week. Now, what I also think is interesting is how it's really created a collaborative environment between hospital networks, which previously hasn't really existed. And I think something that's moving forward in post-corona that would be really interesting is whether or not we continue to have telehealth or video conferencing or pre-recorded lectures that are delivered, and whether or not they can extend to hospital networks outside of the hospital network that that content is delivered in. To try and mitigate some of the education disparities that exist between rural centres and regional centres and the large metropolitan hospitals. I also think a lot has to be said for the particular stresses affecting junior doctors in relation to redeployment and redistribution. People having rotation change at very last minutes, the impacts that that has had on people being able to have prerequisite rotations, being able to actually experience rotations that they might enjoy for a specialty interest, as we were talking about before. The final thing that I think has been really interesting is the effect that it's had on GP trainees during this time. So in the corona world, we've had a real push towards taking patient care from hospital situations and pushing it back onto GPs to try and manage non-urgent conditions outside hospitals to have follow-up. Yet at the same time, GP trainees, while we've had a massive reliance on them, have been hugely I've had huge problems during coronavirus of GPs not being able to afford having their training and their training being cut down, all this sort of stuff. So on one hand, we've had huge reliance on GPs, yet on the other hand, we've had problems with GP training during coronavirus. So that's sort of been my takeaway messages from corona.
Thanks, Helena. I think you raise an important part, and I think, of course, we don't have a GP training on our panel today, but it's such a huge issue. I think that has been highlighted for GP trainees for a long time. And I think coronavirus has exposed a lot of flaws within the medical training system, not only for GP trainees, but for all trainees as well. And I guess the hotspots around examinations and I guess assessments and I guess all those type of things as well. But I just like to highlight, I guess, the particular difficulties that GP trainees and also other private trainees as well, including sports physician trainees who have had lots of issues around employment and employment conditions, and something definitely that we'll be talking about now and post-COVID as well. Maddie, I'll give you the final say on this question on COVID.
I don't have anything that profound. I think, a huge shout out to Hash and the federal team, by the way, a lot of these issues have been with the impacts on college training programs and the amount of work those guys have done to sort of consistently been communicating to the colleges and pulling them up where they're doing some questionable things has been really reassuring to see as a doctor in training. I think from a Queensland perspective, some of the issues that we've heard about quite a lot has been the RMO shortage. So our workforce, particularly in the rural and regional centres, rely a lot on UK doctors coming over and filling ED spots, and then that gives the rest of our JMOs a bit of a chance to move around in the second half of the year. So I think there's a lot of HHSs that are sort of struggling to figure out how we're going to fix that issue. I think quite a lot of junior doctors who might be hoping to step up into some registrar roles in the second half of the year might have to have that delayed a little bit. The other thing is leave, obviously. So leave sort of being rescinded by people. That was certainly an issue that came up at a couple of different hospitals, but thankfully I've heard mostly good things from various hospital reps, so saying that their leave was able to be rescinded, and hopefully we can all get our leave when we need it next year when we're all burnt out post-COVID. And the other thing is alterations in rotation. So a lot of doctors in training did have a bit of a disruption to their rotation pattern or was redeployed for a few weeks here and there. But again, most of what I heard from various different hospital reps was that a lot of the hospitals were quite accommodating with swaps and things like that. So I think, it's just a testament to see what we can do when everyone's sort of looking out for each other and just trying to get the job done. But still make sure we're all able to turn up to work and get through things. That was just a bit about the Queensland perspective.
Thanks, Maddie. And thanks for the shout out to AMA Federal CDT, I think, and also to all the state CDTs. You're all doing a great job, and I know AMA Victoria CDT and their DIT subdivision, as they call it, are doing a great job in managing the issues around there and their trainees during COVID, given that they're the state with the most, as we know, issues around training at the moment. But of course, you know, we are all fighting at the good fight at federal AMA CDT, and I guess at the state-based level as well. And I guess what I hope this implores, and this, I guess the webinar in general, is we've discussed a lot of issues today, all related and kind of exposed by COVID, I think. But I think it goes to show how much the AMA advocacy, how far it goes, and how many wins we've had during COVID. And there's so many stories of doctors in training emailing us and emailing from New South Wales about border issues and rotation freezes and everything like that. And we've really made significant changes to these doctors in training and their lives by advocating on their behalf and, you know, doing what is right for them. And so it really speaks to, I guess, the power of the AMA, the power of the AMA CDT, and I guess to all of you, and I guess your voices, and you're echoing the voices of thousands of trainees around the country, and I think that can't be understated. So I guess I'll wrap up in saying that thank you to all our panelists for everything that you do, not just this panel. You're all doing amazing work, I guess championing DIT voices. And so I think, you know, it's been great to host this panel with you all and have such great minds alike. And to everyone out there, I think, you know, we're going through tough times, but I think we stick together, we can get through this. Please talk to your colleagues, please talk to the AMA CDT, please talk to, you know, your GPs and the Doctor's Health Advisory Service and everyone around you, because I think together, that's the only way we can get through this, really. So thank you, everyone, for a good night. I hope you enjoy the rest of your evenings, and thank you again to our panelists.
Thanks, Ash.
Thanks, Ash. Thanks for having us.
Thanks, guys. Bye.
Thanks, guys.